Everyone loves an underdog. You know, that Cinderella team who surprises everyone and takes on Goliath. Think about the movie Rocky, The Miracle on Ice, or even Frodo Baggins from The Lord of the Ring. That can happen in healthcare and innovations too. So many doubters, so much pushback, and in the end, it overcomes huge odds. Rapid response teams are one of those ideas. A trend that started with urgency faced great resistance, but spread quickly, and in many cases, it stuck. So, what made this one different? Hi, I'm Bruce Spurlock, a physician and healthcare leader focused on helping professionals and decision makers navigate change with clarity. On Viral Healthcare, we examine the ideas shaping healthcare, what works, what doesn't, and what it really takes to implement them well. So let's start with what rapid response teams are. At their core, RRTs, rapid response teams, or some people call them medical emergency teams, METs, or high acuity recovery teams, HARTs. They're the same thing, and they were designed to solve one specific problem. Patients who were showing signs of deterioration on hospital floors were often not recognized early enough, or they weren't escalated quickly enough, leading to avoidable ICU transfers, cardiac arrests, or worse. So the idea of an RRT was pretty simple. If a patient begins to decline, bring in those experts, the critical care experts, right away to the bedside immediately. Do not wait for the situation to become an emergency. That concept resonated quickly, and what's interesting is just how fast this idea spread. So there was opposition early on. I mentioned that earlier. In the beginning of the movement, there was this data and research that suggested it didn't work, it didn't matter, that on average, nobody really benefited from it, and it was a lot of energy and cost to put it in place. Powerful academic leaders got up at meetings and said, our research suggests it doesn't do it. Our rigorous methodology says it doesn't make a difference. Now, oftentimes, those folks are right. And in fact, when we look at ideas and innovations in the future, we'll just see how important it is to look at the research and the underlying rationale for doing it from a rigorous standpoint. But this time, they substituted what looked like rigor for practicality, and they really didn't spend any time focusing on implementation, and implementation is a big deal. So what was it about rapid response teams that this time it took off in the face of all of that opposition? It didn't spread because they were flashy. They were anything but flashy. They spread because, basically people just recognized the problem they were trying to solve, a real problem, a visible problem, a moment where many clinicians thought, man, we should have acted sooner. That's powerful. When a trend aligns with lived experience, it doesn't take much explanation. People don't have to be convinced because they've seen it. They understand there is a problem and it needs to be solved. So there's this notion of escalation in healthcare, especially in the hospital setting, where a patient or a problem gets worse and their problem rises to a level that demands more intense services. It's a fundamental every aspect of every hospital. In fact, it's one of the two main reasons hospitals exist in the first place. So the question isn't if escalation is going to happen, it is. The question is, will it be done well and in time? So when RRTs were first coming out, people looked at every patient who had a cardiac arrest, we call it a code blue, or who was rapidly, unpredictably sent to the ICU. And almost always, very often, there were signs of deterioration during the preceding 24 hours. We missed it for up to 24 hours before somebody actually crashed. In other words, escalation was happening poorly. Now, there were other factors too. The idea was relatively easy to understand. The intervention felt pretty intuitive. And importantly, it aligned with a broader movement at the time in healthcare around patient safety and early intervention and prevention. This wasn't happening in isolation. It fit the moment. Now here's the part that matters most. Not every organization that adopted rapid response teams saw the same results. Some saw a meaningful reduction in adverse events, but others not so much. So what do you think made the difference? Well, we've studied this and looked at it. We looked at it very hard during the time, and a few things really stood out. First, it was clarity of purpose. Organizations were very clear early on that it was meant to do a specific activity, early interventions, not just crisis response. Second was empowerment, and this was really crucial. The staff had to feel comfortable activating the team. The team couldn't demean them. If there was no need for somebody who wasn't really deteriorating, you had to congratulate them and thank them, because the next time, if they didn't do that, if they felt like they were embarrassed, it was going to be devastating. The person was going to wait and say, I don't want to be embarrassed, I don't want to be shamed into this process. So if it felt you were overreacting or stepping on toes, it couldn't be used effectively. Now, third was integration into the workflow. It wasn't just adding a team, it required changes in communication, escalation pathways, and sometimes even culture. For example, many hospitals allowed patients to even call a rapid response team when they saw their loved one deteriorating. And in fact, they picked up on it sometimes much earlier than the staff did because they were with patients all the time. And fourth was leadership support. When leaders reinforced that early escalation was the right move, utilization increased dramatically. What's interesting is that the success of a trend has less to do with the idea itself, and here's something we've said many times, more to do with how it's implemented. So, was it free? No. No idea, no intervention, no trend is free. Rapid response teams required staffing, real people, real FTE, something that's really challenging for organizations to do. Critical care nurses, respiratory therapists, sometimes physicians. They required training and coordination, and they required ongoing attention and data measurement that they were being used appropriately. For some organizations, this was a significant investment. Now, we had this early clue that RRTs were going to be successful, even with some of these new costs to the organization. It was really fortuitous because it became a differentiator for nurse recruiting. See, when rapid response teams were coming out, there was a nursing shortage all across the country. And those hospitals that promised rapid response teams to the new recruits were often more successful in getting them to join their team. In other words, the new recruits, the less experienced nurses, wanted help. They wanted to be supported. They wanted to be, going into the business of healthcare, feeling much safer, and rapid response teams promised that. So it became a differentiator for hospital, and that was important at the time. But there was one other kind of important thing about the cost-benefit conversation that I'll never forget when we were doing it at the time. When implemented well, RRTs were associated with reductions in cardiac arrests and ICU and earlier interventions, and in some cases even patient outcomes, although that wasn't the predominant factor. But the question was, what does this cost? No, the question is, what does it prevent? And I'll never forget the time when I heard a CFO who told me, Bruce, I didn't cry when we didn't meet budget one quarter, but I did cry when we didn't prevent a preventable death. So that was a really different conversation. We are preventing serious, obvious, difficult, and challenging situations. So how did organizations know when to adopt? This is something we're going to talk about often on viral healthcare. And this is where this one gets really interesting with rapid response teams, because not every hospital adopted rapid response teams at the same time. There, like always, were early adopters who were organizations already focused on patient safety and quality improvement. They were paying attention to the early warning signs. They had looked at their cases of those cardiac arrests or unexpected transfer to the ICUs, and they were talking about this concept of failure to rescue. And oftentimes, some of those early adopters had a dramatic case when it went through the entire hospital that someone had died unnecessarily. A really compelling story that made it a no-brainer. It made it like, why are we showing up here to do our work in the first place? And this was a clarion call to their action. Now, late adopters often came in response to external pressure. So place organizations like the Joint Commission or national commentators or even peer comparison. So timing really mattered, and it really mattered on the effectiveness of the spread and implementations. Organizations that were ready, culturally and operationally, tended to integrate much more effectively this idea of a rapid response teams. Others implemented the structure. It's not that hard to commit to imagine, but they've struggled to fully activate it, to really get to the engagement piece. Engagement is a word we're going to use often in this podcast because it's really important to think about how do you engage people. Which brings us back to a discussion that we've had before, a theme that's been around here many times already in just 4 weeks. Readiness matters, implementation matters. So, where are rapid response team today? Well, it's no longer a trend, it's no longer an innovation. In many organizations, they're standard practice, and they've also been augmented by these electronic warning systems, things that the electronic health record can do. And we're going to talk about that on a future episode because there's some pros and cons to that as well. It's about the idea of escalation, but it's how we manage it and implement it that makes all the difference. Even now, with rapid response teams, we see variation exist. Recent publications show that some organizations implement it well, have pretty successful improvements in reduction of cardiac arrest, reductions in unexpected transfers to the ICU, and potentially even improvements in mortality. And others don't have that. The teams exist, but they're not used consistently. They don't really even measure necessarily whether they're effective, or they're activated too late, or they haven't evolved with the needs of the organization as we develop these electronic warning signals and ways to help people understand deterioration better. What's really interesting is that even successful trends require some kind of maintenance. You just can't turn it on and stop it. So it's sort of like blood pressure. Even when we get it well controlled in patients, we still have to check it from time to time to make sure it's still under control. And we need to adapt when circumstances or the world and the organization changes. So what's the learnings from all of this? What's the take-home message for you from the story of rapid response teams and facing opposition that looked like it could kind of kill it because it wasn't rigorously supported in the medical literature, because powerful leaders said this is not a good idea, it's a waste of time. Successful trends tend to have several different features that we should learn about from this example. First, they solve a clearly recognized problem. The more obvious the problem, the easier it is to solve. And so one of our things is, if it's not obvious, how do we make it obvious? Second, it needs to be easy to understand and less complex to implement. So the more complexity, the harder to describe. It's going to take longer to be able to do that. It's weird to think about simplifying things in healthcare with very smart people, and yet making things easy to understand, making it sense-making is important. Third, it needs to align with broader system priorities, and at the time it was about this movement of quality of page safety and prevention. It needs to be supported by leadership. And fourth, and most importantly, fifth, the most important thing to take away from this, it needs to be implemented thoughtfully. Early research opposing RRT effectiveness didn't study implementation well. And we know from both experience and from now research that implementation is critical and ongoing maintenance is necessary for success to be guaranteed. So implementation where everything works or it doesn't. So as you think about the trends in your organizations, as you think about the new ideas you're considering or you're adopting or you're already in the process of implementing, it might be worth asking a few questions like, is this solving a problem we actually see or we can make more obvious to people? Do we have the culture in the organization to support it? We're going to spend episodes in the future talking about what does it mean to have organizational culture. That's a complex question. Do we have the operational capacity to sustain it? Or are we distracted by hundreds and thousands of different priorities? Are we implementing the idea or just adopting the structure? Because there's a difference. Just things to think about in your organization. Now, if you'd like to continue this conversation, join me live every Tuesday morning, 9 a.m. Pacific, 12 Eastern, on LinkedIn, or follow Viral Healthcare on your preferred podcast platform. There are a lot of them out there. Pick which one you like and follow up Viral Healthcare there. And I'd love to hear from you. Tell me what's going on, what works in your session or it doesn't. And if you have a healthcare trend that you've seen implemented well or not, let me know. I'd love to talk about those kinds of things in the future podcasts. On the next episode of Viral Healthcare, we'll look at a trend that didn't go as well as planned and what healthcare leaders can learn from that. But I wanted to start off with this one with a success story, because we're not anti-innovation. We're about using innovation appropriately, in the right timing, in the right way, with the right implementation. So I want to thank you for listening to Viral Healthcare. If this conversation is helpful, share it with a colleague who's also going through some change times, or someone who's considering new ideas and new trends. And if you'd like to have more thoughtful conversations about the ideas shaping healthcare, be sure to follow the show. I'm Bruce Spurlock, and I'll see you next time.